So for this last session, I will invite Dr. Saad Salim, the Managing Director of Sepsis Canada for the past 3 years, who has extensive experience in health research and grant administration. He graduated from McMaster University with an honors bachelor's degree and a master's in health sciences, completed his PhD in Sweden, and held a CIHR and Alberta Innovates postdoctoral fellowship at the University of Alberta. Dr. Salim has managed multi-site clinical research project as a clinical research assistant and spent 5 years as the vice president, it's lots of stuff in here. It's really impressive. Vice President Research and Innovation Office of the University of Alberta. First as a research facilitator and then as a director of grant assist programs supporting major funding initiatives and investigative research. So thank you so much and welcome. So sorry.
Thank you, Jessica. Welcome, everyone. I hope you're having a very good day today. And it's my pleasure and honor to introduce to you 2 amazing people. First off, we will have Dr. Patricia Liaw, who's going to be talking about immunothrombosis and sepsis, prognostic and therapeutic strategies. Dr. Liaw is a professor in the Department of Medicine at McMaster University. She holds the Jack Hirsch and Clive Kieron Endowed Chair in Thrombosis Research. She's also the chair of the Canadian Critical Care Translational Biology Group. In 2024, she received the CIHR CSATVB, don't ask me what that is, Scientific Excellence Award in Blood and Blood Vessel Sciences. Dr. Liaw's research focuses on the crosstalk between microbial infection, innate immunity, and blood clotting, a process termed immunothrombosis. Her research integrates lab-based studies with translational clinical research projects to better understand how immunothrombosis contributes to morbidity, mortality in sepsis, and disseminated intravascular coagulation, DIC. Please help me to give a round of applause to welcome Dr. Patricia Liaw to give her talk.
So there's 2 remotes. Are they interchangeable? This one's good? All right. Well, thank you very much for the kind introduction. It's a pleasure to be here today, and I'll be discussing our research on immunothrombosis in sepsis, prognostic and therapeutic strategies. My research lab and office are located at McMaster University at the Thrombosis and Atherosclerosis Research Institute. And you can see that it's situated right next to the Hamilton General Hospital. So it provides a unique opportunity to engage in translational studies in critical care. And I would just like to acknowledge my longstanding colleague and collaborator, Dr. Alison Fox-Robichaud, who's also the director of Sepsis Canada, for a lot of the enthusiasm and expertise behind the research that we do. So the speakers were encouraged to have an interactive component in their presentation. So for me, this will be a quiz with a prize that I have picked out myself at the end of the presentation. And I would like to encourage the trainees to participate in the quiz because you can actually win something. So as we heard already, sepsis is a life-threatening complication of infection. There are many different pathogens and many different sites of infection, including bloodstream infections, infections of the skin or soft tissue, catheter-related infections, abdominal infections, and also infections in the brain. The World Health Organization has called for global action on sepsis, given that it's a cause of 1 in 5 deaths worldwide. There are over 50 million cases of sepsis per year, with over 11 million deaths. In Canada, it's responsible for 1 in 18 deaths at a cost of almost $2 billion annually. The mortality rate ranges between 20% for sepsis and up to 50% for patients with septic shock. Sepsis can cause death by 2 main mechanisms. The first is related to uncontrolled growth of the pathogen, which we term the microbial cause. So the bacterial antimicrobial resistance, as we've already heard, accounts for over 2 million deaths It's driven by misuse and overuse of antimicrobials in humans, plants, and animals. And the economic burden in the US is almost $4 billion annually. There are many mechanisms for the resistance. The intrinsic mechanisms are related to factors such as natural resistance, the ability to modify the target, the ability to pump out the antibiotics, and the ability to produce enzymes that inactivate antibiotics. There are also mechanisms related to the formation of bacterial biofilms, which consist mainly of extracellular DNA, polysaccharides, and lipids. So within the bacterial life cycle, they can colonize surfaces, which causes the bacteria to aggregate and attach, forming these microcolonies, which after maturation could disperse, which results in this repeat of the cycle. So the other major mechanism by which sepsis can cause death is through collateral tissue damage caused by an overactive immune system, which we refer to as a dysregulated host response. And this can impact the major systems in the body, including the cardiovascular system, hepatic, respiratory, renal, hematological, as well as the neurological system. So my research focuses on immunothrombosis, which is at the front line of intravascular immunity. When we think of thrombosis, we often think of it as a pathologic process that occurs in response to injury of the lining of blood vessels, activation of platelets, and initiation of the blood coagulation cascade. But thrombosis can actually serve a protective role because blood clots can help to trap microorganisms. And this is initiated by innate immune cells, notably monocytes as well as neutrophils. So in immunothrombosis, there's multidirectional crosstalk between the innate immune system, endothelial injury, platelet activation, and blood clotting. The infection-induced blood clots are beneficial to trap pathogens, but they can also lead to pathologic clots in the case of severe infections. So we can think of immunothrombosis as being a double-edged sword. It exerts protective effects through killing of microorganisms, but if unregulated, it can exert harmful effects through impairing tissue perfusion, injuring endothelial cells, and in severe cases, it can lead to disseminated intravascular coagulation. There are many common mechanisms by which pathogens can induce blood clots, and I've shown here an example of gram-negative bacteria as well as envelope viruses. Both forms of microorganisms can trigger clotting through the increased expression of a protein called tissue factor, which is the initiator of the clotting cascade. So for bacteria, that's through binding to toll-like receptors on immune cells. For envelope viruses, they actually acquire host-derived tissue factor. This can lead to increased inflammation through the secretion of inflammatory cytokines from activated monocytes. This leads to injury of the lining of blood vessels. So you now have a switch from a thromboresistant phenotype to a pro-thrombotic phenotype with loss of natural anticoagulants. At the same time, platelets become activated. They will induce neutrophils to release chromatin, resulting in the formation of what are called neutrophil extracellular traps. And the ultimate result is immunothrombosis, in which you have clots containing not only fibrin, platelets, and red blood cells, but also immune cells and their toxic molecules. There have been over 60 clinical trials performed in sepsis, involving over 22,000 patients. Despite very promising results in preclinical animal studies, none of these therapies have resulted in new treatment strategies. The trials include interventions that dampen inflammation, neutralize endotoxins, and even inhibiting blood clotting, as in the case of activated protein C. So the question is, why have clinical trials in sepsis failed? There are several potential reasons. The first is the choice of animal models. What is the best animal model to use, and is it possible to standardize the models? The second is the choice of timing. The onset of sepsis, as we've heard, is difficult to define clinically, and the target of the therapy may actually change over time as the disease progresses or resolves. The third is the choice of intervention. What is the correct target? Will single therapies be effective given the complexity of the immune response in sepsis? And then lastly, choice of population. There is heterogeneity in the patients and process of care. Stratification systems may be needed to guide treatment decisions. And we'll hear much more about this in the next talk by Dr. Hancock. So focusing on the preclinical animal studies that have led to the development of anti-sepsis therapies. There are methodological challenges in preclinical animal research. Unlike human research, animal research is often single-centered. They're not randomized. There are no sample size calculations, and there's a bias towards publishing positive results. There are also variations in the protocol, which makes it difficult to reproduce between different sites. In contrast, clinical research is often multi-center, randomized, adequately powered, with shared protocols and standardized reporting. So back in 2019, the National Preclinical Sepsis Platform, also called NPSP, was created. This is co-led by Drs. Manoj Laloo, Asher Mendelson, and Braden McDonald, with support from Sepsis Canada and also the Canadian Critical Care Translational Biology Group. The goal of the NPSP is to create a multi-center infrastructure to allow us to rigorously study the pathophysiology of sepsis and to accelerate the movement of promising therapies into early phase clinical trials. So the goals are to create a multi-laboratory infrastructure using standardized models and including blinding as well as both biological sexes. There's also inclusion of supportive care that is clinically relevant, so use of antibiotics and fluid resuscitation. And as I mentioned, the goal is to generate adequately powered, high-quality data that can accelerate the movement of novel therapies into early clinical testing. So this is one of the models that the NPSP has developed, is a model of abdominal sepsis using fecal-induced peritonitis. The advantage of this model is that we can create a large batch of rat-derived fecal slurry that we freeze in thousands of aliquots that can be shared across the country. It's a simple technique. It's intraperitoneal injection into healthy mice. We can alter the severity of sepsis by changing how much of the fecal slurry we're injecting. We have standardized methods for tissue and blood collection. We use both sexes, and we use young as well as aged animals. And of course, clinically relevant treatments, including antibiotics and fluids, are included. So in Canada, we aren't allowed to have death as an endpoint for most studies of sepsis. So it's important to have standardized scoring systems for humane endpoints. And this is an example of this scoring system that we have standardized. So the other potential reason is the choice of timing, given that the onset of sepsis is difficult to define. We can think of sepsis as a clinical state that falls along a continuum of pathophysiological states. The initial infection could be cleared, resulting in the resolution of inflammation, but if not, this can lead to sepsis, septic shock, multiple organ dysfunction, and ultimately death. In recent years, there's been renewed interest in heparin as a potential therapy for sepsis. Heparin is best known as a blood thinner. It has the ability to inhibit several of the enzymes within the coagulation cascade. But it also has anti-inflammatory, antimicrobial, and cytoprotective properties. So we go back to this diagram, we can see that heparin has the ability to target multiple pathways that are important in infection-induced immunothrombosis. So in animal models, we've shown that administration of heparin in septic mice reduces mortality. It also improves survival by reducing bacterial loads, inhibits clotting, and lowers the formation of neutrophil extracellular traps. In human phase 3 clinical trials, therapeutic dose heparin has been shown to be effective in moderately ill, but not in critically ill patients. So in the early stage of sepsis is when therapeutic dose heparin might be the most beneficial. In contrast, the clinical trials of the IL-6 receptor antagonists have shown the opposite. With this approach, the antagonist seems to be beneficial in critically ill patients, but not in moderately ill patients. So using this model of fecal-induced peritonitis, we have the opportunity to look at the optimal time of administration of investigational antisepsis therapies. So using heparin as an example, we can induce sepsis at time 0, and then we can inject heparin at different time points to monitor its effect on survival and also to look at its ability to improve organ function and to decrease markers of inflammation and clotting and cell death. What we found is similar to what has been observed in the human studies, that there is an optimal time frame to administer heparin. It's somewhere between 8 and 12 hours post-infection. If the drug is administered too early or too late, there is no beneficial effect. And this may be related to the fact that blood clotting is beneficial in the early stages of sepsis. It does help to trap and eliminate microorganisms. In the later stages, it may have reached the point of no return so that heparin is no longer effective in terms of improving survival. So we just look at the timing based on clinical and animal studies. It seems that therapeutic dose heparin may be beneficial in the earlier stages, and in the clinical trials, IL-6 receptor antagonists may be beneficial in the later stages. Moving on to the choice of intervention, what is the best target, and will single therapies be effective? Over several years ago, Alison Fox-Robichaud and I collaborated to look at plasma biomarkers in ICU patients with sepsis. And we found that plasma from ICU patients with sepsis have very high levels of extracellular DNA that, based on DNA methylation profiles, is released mainly by activated immune cells. We also found that the DNA is a potent trigger of blood clotting. So it initiates clotting through factor 12 and 11. It alters the morphology of blood clots, and it prevents clot breakdown. So if we extract circulating DNA from a patient with sepsis and we add it to healthy plasma, the plasma clots almost immediately. We also find that it alters the architecture of the clotted cell. So the fibrin strands in a healthy individual plasma are rather thin, but in ICU patients with sepsis with very high levels of circulating DNA, the plasma fibrin clots are much thicker and resistant to degradation by plasmin. So we hypothesized that perhaps recombinant DNase 1, which is a naturally occurring enzyme that has the ability to degrade DNA, maybe it's a potential therapy to target immunothrombosis. And I've shown the enzyme here as a pair of scissors. It has the ability to degrade the phosphate backbone of circulating DNA. By doing so, it could liberate the immune cells, the platelets, and improve blood flow. So interestingly, DNase 1 enzyme is also effective against bacterial biofilms. So there are stages of bacterial biofilm development, which I mentioned earlier, starting with reversible attachment, irreversible attachment, maturation, and then dispersion from the interior. And a paper by Tetz and al. Showed that treatment of bacterial biofilms with this enzyme that degrades extracellular DNA has the ability to alter biofilm characteristics. And they also showed that treatment of bacterial biofilms with DNase 1 plus antibiotics is the most effective. They hypothesized that the enzyme will permit the increased penetration of antibiotics. So if you look at biofilm formation, this is control treatment. And then when DNase or the combination of antibiotics and DNase is added, there's reduced biofilm formation. In animal models, we found that administration of the enzyme intravenously does improve outcome, and it's most effective when given at the later stages of sepsis. So just adding to this timeline, at least in animal models, it seems that DNase 1 is effective in the later stages. So then we asked, do high levels of circulating DNA predict poor outcome in humans? And if so, will reducing levels of plasma DNA improve survival? So we were funded by CIHR to conduct a multi-center prospective observational study involving 9 academic ICUs across Canada. We had a sample size of 400 sepsis patients, 400 non-sepsis patients, and we collected the data for up to 28 days, so clinical data as well as blood samples. So to conduct translational research at the national level, we were fortunate to have the support of the Canadian Critical Care Translational Biology Group. The CCC-TBG currently has over 80 members, including intensivists, PhD scientists, trainees, research coordinators. We have developed over 20 research programs that focus on molecular mechanisms, discovery of novel biomarkers, and translation of discoveries to the bedside in the context of critical illness. What we found was that high levels of circulating DNA does in fact predict poor outcome. We also found that ICU patients with sepsis have acquired deficiency of DNase 1. So the enzyme that is naturally occurring and serves to degrade extracellular DNA is reduced. You can see here on the left that the levels in ICU patients are roughly 50% of that in healthy individuals. We also, in healthy individuals, the enzyme is currently approved as an inhalation aerosol for the treatment of patients with cystic fibrosis. So the inhaled drug can actually digest the extracellular DNA in the patients and reduce viscosity in the lungs. We have a CIHR-funded phase 1 clinical trial to look at intravenous delivery of DNase 1. So it's currently approved as an inhaled drug. It's never been tested intravenously. So our study is a phase 1 safety and feasibility study involving McMaster University and the University of Montreal. It's a phase 1 open label dose escalation study where the drug is administered intravenously at 2 different doses for either 3 days or 7 days. Finally, the choice of population is also important in terms of the success of clinical trials. Will one size fit all in the treatment of sepsis? This is an excellent review article that was published by Hector Wong, which shows that there is value to have prognostic as well as predictive enrichment strategies in the treatment of sepsis. For prognostic enrichment, the patients would be stratified based on mortality risk. The patients with low risk would be treated with standard of care. Those with higher risk could be further stratified using predictive enrichment, and this may be helpful for targeted therapy where the specific treatment is effective for a certain biological mechanism. So in the multi-center observational study, we were also looking at indicators that would predict poor outcome. We hypothesized that routine hospital parameters such as platelet count, lactate, creatinine, as well as the Glasgow Coma Score, as well as extracellular DNA and protein C, which is a natural anticoagulant, may have the ability to generate personalized mortality risk profiles. So this is an example of the profile for one of the 400 patients in the study. For this patient, it suggests that acquired protein C deficiency, so they're now missing a natural anticoagulant, is a major contributor to the patient's risk of dying. So for this particular patient, perhaps anticoagulant therapy may be the most appropriate. So this is just an example of the algorithm that can be used where the values of the indicators are inputted on day 1, as well as a subsequent day in the ICU, and then the mortality risk profiles can then be generated. So our vision is to have a targeted approach in future clinical trials with prognostic as well as predictive enrichment. So having a point of care device that can measure these parameters would give us not only the probability of dying on a specific day, but also identifies which indicator contributes the most to the mortality risk, and then that can be used for targeted therapy. So just to summarize, there are several strategies that may help to overcome barriers in sepsis research. These include standardizing animal models, identifying the optimal time frame of therapies, investigating novel therapies, and then having enrichment strategies built into clinical trials. So the goal is to select the right treatment at the right time and at the optimal dose for the right patient. Just to summarize, sepsis remains a global medical emergency with over 11 million lives lost each year. The potential reasons for the failure of previous clinical trials may be related to the choice of animal models, timing, the target, and heterogeneity in the patients themselves. The National Preclinical Sepsis Platform may be useful for providing standardized animal models for sepsis. New therapies could consider targeting multiple pathways in infection-induced immunothrombosis. And knowledge gaps include the incorporation of enrichment strategies into clinical trials, for example, guided by biomarkers. And I'd just like to acknowledge past and present members of my lab, many colleagues within McMaster University, the Canadian Critical Care Translational Biology Group, the Trials Group, and our collaborators in Montreal. So this is the quiz that ChatGPT generated. I don't know where it found this information, but I do have a prize. It says, in addition to her research in sepsis and immunothrombosis, Dr. Liaw has a unique personal hobby that helps her unwind. Which of the following is one of Dr. Liaw's favorite pastimes? Competitive rock climbing, playing ice hockey, relearning calculus, or playing the violin in a local orchestra? I'm looking for trainees.
It's got nothing to do with the presentation.
Well, it kept them focused.
It's true.
Yes. Playing the violin, unfortunately, no. You now have a 1 in 3 chance. Yes. Correct, playing ice hockey. Definitely not relearning calculus.
Yes.
Thank you for your attention.
Thank you. Thank you, Dr. Liaw. We have a few minutes for some questions. If you would like to ask a question, please go to the mic. There's one there, and there's one other there as on that side as well.
No questions.
No question? Maybe I can ask you one.
Sure.
So we're in the AMR Symposium right now. So how would you tie in antimicrobial resistance to the model that you had shared with us? And how would that fit in with the timing, the dosage, and everything?
So I think one of the advantages of using the animal model is that we can control when the infection starts. So for example, if we want to see whether or not antibiotics have the ability to alter the microbiome, that then has the ability to impact a secondary infection, we can definitely do that. So that's one of our ongoing studies to collect the fecal contents of mice treated with and without antibiotics, and then looking at how the microbiome changes. We're also looking at immune profiling as well in the model. For the DNase 1, we haven't directly looked at its impact on bacterial biofilms in the phase 1 clinical study, but in vitro, that's something that we can definitely look at in more depth as well.
Thank you. Please say your name and where you're from.
Hello, I was wondering if you could let me know if you have any experience with metal chelators as potential treatments for sepsis, so like EDTA, for example?
We haven't used metal chelators. In blood clotting, we collect blood into EDTA to prevent clotting. So I guess if you added metal chelators to the point where you're removing all of the calcium, you probably would prevent clotting as well. Are you thinking chelators that directly have antimicrobial properties? I guess it depends on the dose as well.
Yeah, it depends on a lot of stuff. I'm just wondering if it's been thought of. That's all.
We haven't looked at that, but definitely something that we can test in the animal model.
Thank you. Yes.
Hi, I'm Nikki Weckman from the University of Toronto. In your dynamics study, I love the idea of using that panel of biomarkers to kind of predict people's risk and stuff. So are you also collecting physical biomarkers and symptoms, for example, and feeding that into your risk prediction scores? Or are you doing those kind of completely independently and separately?
So one of the components is the Glasgow Coma score that was in that. Other than that, it was platelet count, creatinine, lactate, and then 2 of the other biomarkers. We did look at whether or not the site or the type of infection impacted outcome, and it didn't seem to. But in terms of inclusion criteria, we have, at least for the dynamic study, we have the Apache 2 score, we've got the SOFA score, and we have the MOD score for inclusion. Does that help to answer your question?
That's perfect, thank you.